All right, guys, it's 4 o'clock. We'll kick off on time. Welcome everyone to another edition of Tumor Talk. This is the collaborative effort between the Journal of Neuro-Oncology and Lennoxville Neurosurgery, where we highlight recent publications in the journal, and we talk about kind of the rationale behind the study, the results, and really the relevance for both the patients, their families, and practitioners as well. So today, super happy to have two guests with us discussing a recent publication on the use of PET for malignant gliomas and brain metastases. And so why don't you guys introduce yourselves, tell us where you're from, and we can get started.
Sure. Go ahead, Jay.
All right. So I'm Jay Detsky. I am a CNS radiation oncologist at the Odette Cancer Center, which is at Sunnybrook Hospital in Toronto, Ontario, Canada. Trained here in Toronto, and I have an active area of research looking at radiation therapy and imaging outcomes and prediction tools for both brain metastases and gliomas.
My name is Amit Singnurkar. I also work at Sunnybrook Health Sciences Center with Jay. I'm a nuclear medicine physician by training with specialty training in nuclear oncology. And my primary research interest is in neuroimaging, both for cancer and also for dementias.
Amazing. Do you guys have a PowerPoint or anything?
I have a PowerPoint. I can share it.
Yeah, let's do that.
And then Jay, you can go through the first few slides.
Sure. When it's up, I was going to go over some of the clinical motivation behind doing this meta-analysis to better understand where we are and where we need to go for using FET PET in the diagnosis and management of CNS malignancies. I don't see the slides yet.
Yeah, Zoom just upgraded, so
give it a minute.
Yeah.
No worries. Well, we're super happy to have you here. This is something that comes up very often in our own tumor board discussions. And I'm curious, what the data has shown.
Sure. I can.
We lost them.
I have the slides, so I can start sharing.
Oh, excellent.
I have them as well, luckily. Here we go. I'm not going to make it full screen because it's going to go onto the wrong screen, so I'll just do it like this for now. Very, very briefly, CNS tumors are primary tumors or secondary metastatic tumors. All of the secondary tumors, brain metastases, have a relatively poor prognosis, but there are increasing options for treating them, and a lot of them involve radiation and some surgical. And then gliomas, specifically high-grade gliomas, are considered incurable. But again, we're working on better understanding what's going on so we can tailor our treatments and hopefully improve outcomes. Hopefully you can see the slides. Yeah, okay.
Yeah, looks great.
So some of the specific areas where PET imaging can really play a role is first of all in gliomas. After maximally safe resection, it can be really hard in the postoperative setting to determine where is the tumor or what is tumor versus what is postoperative changes. And especially in glioblastoma, there is autopsy studies showing that there is microscopic disease within the non-enhancing flare signal. But is all flare signal the same? That's what we don't know. Are there areas around the gross tumor, if there is gross tumor left over, that have more tumor that needs to be treated? And are there areas that are simply edematous and high flare signal and don't need to be treated? And so that's one aspect of really defining radiation treatment volumes. And then, of course, after treatment, pseudoprogression, which is a apparent increase in enhancement in size, typically 1 to 3 months after radiation, is commonly seen. It's hard to differentiate from true early tumor progressors. And then late radiation necrosis is also sometimes hard to differentiate between tumor. And then in the setting of brain metastases, radiosurgery is increasingly being used for many metastases now. And we know about 10% of the brain mets that we treat with radiosurgery experience radiation necrosis, and about half of those are symptomatic. But what I see every single week, I treat a lot of brain metastases, is a follow-up scan that suggests 2 millimeters or 4 millimeters of growth of a radiated brain metastasis. And I just don't know if it's tumor, in which case we might need surgery or more radiation, or if it's radiation necrosis, which we treat more conservatively. And so that's where we need better biological imaging to understand what's going on in these scenarios to help guide actual patient management. So maybe I'll stop sharing, and maybe Amit, if you want to share and then can go full screen.
Yeah. Are you seeing my slides?
Yes, looks good.
Okay, sorry about that. Oops. Okay, so thanks for the intro, Jay, and thanks for rescuing the first part of this test, of this talk. So the molecule we're interested in is FET. So a FET is a amino acid. It's a small molecule. You see it on the left-hand side. It's labeled by 18F, which is the radioactive atom that we image with the PET imaging cameras. And so what's interesting about this molecule is that it's taken up by brain malignancies, high-grade gliomas, low-grade gliomas, and brain metastases because they express LAT1, which is an amino acid transporter. The other thing that's useful about this agent is that it crosses the blood-brain barrier. So, despite any previous intervention, it will not really affect the imaging quality of this examination. So, so that's the focus of this talk. In the middle, I placed an example image of a FET PET MRI. And so this is an image of a patient with high-grade glioma. The blue arrow points to an area of gross tumor volume that's visible on MRI. It's difficult to see because it's a fused image, but the pink or violet arrow shows areas that were occult on MRI and can be shown with PET imaging. So this is the reason why there's so much interest in this technique is, can we better define, tumor activity compared to the conventional MRI technology that we have today. So before we go on, the literature in this area is, I would say, still quite early. This is not done in all jurisdictions. I would say most of the centers doing this are currently in Europe. And so a number of different things have been reported. There are different PET measurements that we can do with PET imaging. So I'll divide them up into static imaging and the dynamic parameters. And so under the static, you have SUV, which I'm sure most people have heard of, which is standardized uptake value. We use it all the time in FDG PET imaging. Tumor to background ratio, it is exactly what it says. We compare the uptake in the tumor to some background area. Metabolic tumor volume, which is the volume delineated by some threshold that the user sets to see what the biologic volume is. And then dynamic parameters, which are time activity curve, time to peak. There are many others, but these two just to be kind of concise. And the reason why dynamic imaging is interesting is because several investigations have found that the dynamism of PET uptake, actually relates to whether there's viable tumor versus no viable tumor. It also relates to the grade of the tumor. So there's a lot of information we can actually derive from dynamic imaging. What I'm about to describe later on in the slides is focused on static imaging, but there's a lot of literature on dynamic imaging as well. So we started this work because there is an increased interest and signal in the literature about the utility of PET imaging in brain malignancies. And so we want to figure out what is the diagnostic performance and clinical impact of FET PET in two broad areas. So high-grade gliomas and brain mets. So under high-grade gliomas, we looked at, is this useful for pre-treatment planning? Is this useful in the assessment of treatment response? Can this help us distinguish recurrence from post-treatment changes? And similarly in brain mets, as Jay was describing, again, we want to figure out, can this be helpful in defining whether the changes we're seeing on MRI are based on recurrence or post-treatment change? So very important questions, which we have a lot of difficulty answering with current technology. So methodology, again, our colleague couldn't be here, but I'll summarize as best I can what we did. So we looked at electronic databases of literature. We looked at English articles evaluating PET, PET-CT, or PET MRI. So these are all different flavors of PET imaging fused to CT or MRI. They had to have something quantitative that we could summarize or at least evaluate. We used the composite reference standard of post-surgical or post-biopsy histology, clinical or radiologic follow-up. It turned out to be radiologic follow-up. There were no studies that only had clinical follow-up. And then, just because of the patient population and because of the relative nascency of this area, we elected to go with smaller studies. So 12 or more patients in prospective studies, 20 more patients in retrospective studies. And based on this, we were able to come up with some summary data. We excluded commentaries, editorials. We excluded studies that had more than 20% low-grade gliomas. And the reason behind this is biologically, they behave differently. And they also behave differently on our imaging. And so we excluded them because we didn't want to dilute the impact of imaging in these areas. And we also excluded studies that address radiomic features, because if you think there's a lot of variability in practice with just static and dynamic imaging, there's even more variability in radiomics. So we decided not to even go there. Okay, so these are the results. In summary, we found over 2,200 articles. And then basically, this goes over how we excluded the articles. In the end, we came up with 26 articles for a qualitative synthesis, which you'll see on subsequent slides, and then 19 of which we used for these summary statistics or meta-analysis. Okay, so there were a total of 26 studies with 1,206 lesions. I say lesions because the glioma patients, essentially, they were a per patient evaluation. In the metastasis group, there were multiple metastases per patient. Of the studies, 5 were prospective, 21 were retrospective. In terms of tumor types, 21 were for high-grade gliomas and only 5 were for brain mets. And then basically you have a breakdown of how many were prospective and retrospective in those 2 different categories. Again, we used the composite reference standard, so imaging follow-up, and then we had histology for 425 lesions, 345 for high-grade gliomas, and 80 for brain mets. Again, that's pretty good. It's about a third of patients. So in terms of a clinical questions, remember, we had 3 questions under high-grade gliomas. So can this technique, does this have any value in assisting us in radiation therapy planning, right? So we found 3 studies looking at radiotherapy target volume delineation. And what these studies found is that around 40% of the time, there was more than a 20 millimeter change in the boundary defined by FET imaging as compared to MRI imaging. So we're not surprised to find this, but so that can have an impact on how you plan your patients. The second question was assessment of treatment response. So a lot of this literature was more qualitative. There weren't enough articles to really provide summary statistics. So one study basically described how the early response on FET uptake can predict overall survival. And so we found that tumor to background ratio decrease of more than 20%. In those patients tend to survive longer, about 16 months compared to only 9 months for those who did not have that change. And then the volumes detected on contrast-enhanced MRI didn't really detect a change in those patients. In patients with progressive glioblastoma, PET was better at identifying early responders to a specific treatment regimen, and MRI was not predictive of these early responders. And then one study looked at in the immediate post-operative setting, which is within 72 hours, they compared FET PET CT to contrast-enhanced MRI to see if they could predict what the areas of later recurrence would be. And so, in this study, they found that FET PET CT had a better diagnostic performance compared to MRI. And in those patients where MRI did not detect a difference, more than 60% would have shown that area had they been imaged with PET imaging. So it seems that there is a signal that, FET PET provides some more prognostic information compared to MRI. Okay, our last question under high-grade gliomas was, can FET PET imaging help us distinguish recurrence from post-treatment changes? Okay, so on the left-hand side, I have quite a few comments and caveats. So most studies, so the first point is, an area of potential bias, right? So most studies were done because there was already some pre-existing suspicion that there might be recurrence. It's not a prospective study done at a specific time point. Another study was only, simultaneous FET PET MRI imaging, and we don't know, what impact the MRI had on these patients. Another study was evaluating patients with adjuvant intracavitary radioimmunotherapy. So this is a specific patient population. And then again, there was a lot of variability in terms of how they were evaluated. So dynamic features, static features, combination dynamic static features, different cutoffs. And so our job was really to distill, what is common within these different studies that we can summarize, that we can make some sense out of. Okay, so we found that most studies use tumor to background ratio. And so again, the cutoffs were different, but we're able to kind of cluster them so that we use the cutoff between 1.9 to 2.3. And based on this, we were able to provide some summaries. And so this set of studies, which was summarized, showed a 91% sensitivity and 84% specificity in distinguishing tumor recurrence from treatment-related changes in this patient population. The other interesting thing was, now how does this compare to what's already available? So there are no great studies comparing FET PET to MRI, right? So that's very important when you're kind of making this decision. The best we could do was, there was a subset of studies that also had diffusion-weighted imaging, so ADC maps. So we're able to compare the FET PET imaging to MRI, this specific sequence, and we found that again the AUC was greater in the FET PET imaging versus the MRI. So 0.92 versus 0.71. So this suggests that there's some increased ability to discriminate viable tumor from benign changes. Similarly, for brain mets, we had a similar question. And so again, we were faced with the same limitations where the evaluation criteria were quite different between different studies. Again, we found that tumor to background ratio was the most reproducible measure between studies. So again, we chose a kind of a small interval on which to evaluate this study. So we chose 2.15 to 3.11 as the cutoff criteria. And with this cutoff, the AUC was 0.89, which is pretty good. So to summarize, and Jay, chime in when you want to, it seems that FET PET imaging compared to MRI may have some impact in terms of affecting radiation treatment volumes. It does provide some complementary information compared to MRI in terms of prognostication and prediction of where the tumor is going to recur. Pooled analysis show that there may be some value in distinguishing recurrence from treatment-related changes, both in the brain met setting and the high-grade glioma setting. But I think it's important to note that we're not sure how changes related to FET PET imaging guided therapy actually affects outcomes, right? So those studies have not really been done. But one thing of note is that this is gaining some traction. There has been endorsement by the nuclear medicine communities and the nuclear oncology communities, both in Europe and North America. And they did provide some, combined endorsement for this technique and other amino acid imaging techniques. So it is something that's been recognized by respective societies and something that we're actively working on as an academic community. Finally, some limitations. So again, the sample sizes were quite small. Many of the studies were retrospective. There were different cutoff values and different technical evaluations. Again, we don't know what the source of bias would be in these study populations. So that kind of sets us up to think about what is the future research in this area going to have to be. So the number one thing in terms of, from a very technical standpoint, from the imaging standpoint, technically some of the studies were quite different. And so we have to kind of converge upon some fixed technique that we can evaluate across multiple different centers to ensure reproducibility. The other thing is that once we have a fixed technique, then we have to figure out, what is the best measurement? Is it going to be dynamic? Is it going to be static? Is it going to be some combination? And this, again, has to be evaluated in a prospective manner, ideally across different centers, looking at important outcomes such as, survival and also quality of life. So that concludes our presentation in terms of the results, what the results are and our thoughts around it. Jay, any comments before we open it up for questions?
I would just add in, part of the motivation for doing this is to see what's been looked at before and where do we need to go. But there's also, very simply, one of our questions was, it seems that tumor to background ratio is probably the most commonly used metric. But the question is, if we're going to design a study and we're going to, design a study where we use FET and versus we don't, what tumor to background ratio should we use to define tumor? Because you can pick any number and skew things any way you want. So part of the motivation is simply, one of the motivations is simply what TBR should we be using based on previous studies to define some kind of prospective study moving forward. And I think we did that, and we have an understanding for gliomas and brain mets what TBR we should be using, at least a fairly small range, and we can pick something within that range. And the key is to try to get other places. A lot of this data is very, very European focused. And so we want to encourage everywhere to get involved and start looking at this with some kind of uniformity so we can pool stuff together, better studies down the road, and try to get some answers in terms of, can we improve outcomes, or can we improve diagnostic dilemmas by using this technology?
Guys, great job. I mean, number one, we always start by thanking everyone for considering the Journal of Neuro-Oncology. I think it's a pleasure to publish papers like this in the journal, and I speak on behalf of Jason for that. It's very well thought out. It's very clean. The data is good. It's a super interesting topic, and I just want to congratulate you all on it. It's very, very informative and also intriguing in terms of its questions and kind of the future of these imaging modalities. I have a ton of questions. I don't know how much time we have. We'll try to throw some easy ones your guys' way, and we'll also open it up to the audience if anyone has any specific questions they want to ask through the chat. My first question to you is, why FET PET? I know there are different tracers, and you kind of alluded to this a little bit in the beginning, but obviously it's a lot of work that goes into just one tracer, and I know that other people are looking at other ones. Have you guys thought about the other tracers at all? What makes this so attractive?
So the other tracer I would say that has been most evaluated is C11 methionine, and so there's a lot of publication around that. The problem when you think about this, when you really want to take a tracer forward from the research to more of the practice environment is, in nuclear medicine, we always think about how feasible is this to do, right? So C11 requires a cyclotron in very close proximity to a PET scanner. So, the half-life of C11 is 20 minutes, right? Whereas for fluorine is 110 minutes, right? So that allows you to, create the trace at a central facility and distribute it to different centers, right? So what we want is, we don't want this only available at large oncology, large research centers. We want this to disseminate across the clinical community, whether that be academic practice or clinical practice. So that's the reason why I think there's a lot of interest in 18F PET, because it behaves very similarly to C11 methionine, and they have been compared head to head. So we're not really losing anything by doing 18F PET imaging. But in terms of deployment, it's much easier and much more reasonable to deploy it and make an economic case for the companies that would produce this trace in the future.
So I see. And have you guys been doing this routinely in your own institution now?
We're not. We're actually also at the evaluation stage, right? So this is not. So we're in Ontario, and this tracer is not yet funded, and so this is being done. And we're trying to answer some of the questions that we come up with during this review. We're trying to figure out how this changes management, and what are the impacts on outcomes, et cetera. And we're doing this in a prospective manner. So. So these are hopefully these studies will come out in the next year or two.
I'm just curious because, when you talk about being able to predict the site of recurrence, all I think about is, can it predict where we should have done more surgery, right? If that's the most likely area that's going to recur. I mean, number one, it probably means we left something behind, which, hopefully is not the case if you're at a good institution and you're using 5-ALA and the usual. But we all know that there are things that happen that limit things like that. And so, I don't know if you guys have looked at this or if the data has been published on preoperative use to help guide surgery or fusion with an MRI preoperatively or not.
Well, yeah, it has been done in a preoperative setting. I can tell you as a researcher, it's very tough to recruit these patients because there's quite a bit of acuity, as you know.
Yeah.
But typically, what's shown is that there's a large amount of tumor that's shown on PET imaging compared to conventional MRI. But then I would pose a question back to you is, you want to spare morbidity and spare the eloquent areas. And so, it's not clear to me what impact this would have. It may have some impact. But, certainly in a pre-radiation setting, it kind of makes sense to do this imaging, but in the pre-surgical setting, it may make sense, but I'm not sure what the impact would be. But this imaging has been done in the preoperative setting.
I would just add, I love the neurosurgeons I work with. They're extremely thoughtful, but in glioblastoma, you can't get it all. Like it always comes back, right? Yeah. Everything that's visible, sure, but there's always some tumor cells left behind. So I don't think it's a matter of the surgeon can do better if they had better imaging. I think this is where is the most sort of aggressive microscopic disease that's left behind, or the most treatment resistant. There's always microscopic disease somewhere. Where is the most treatment resistant area that's going to grow back first? And couldn't we target that better with earlier interventions? Maybe more radiation, maybe salvage surgery earlier at any site, at any hint of recurrence, informed by sort of a FET PET. So those are the sort of things I think we need to think about, because unfortunately it's still an incurable disease.
Yeah, I mean, I say this all the time, but it's not a surgical disease. It is in the acute setting, but ultimately, it won't be. But I think that's a great answer, and I think it makes a ton of sense. Philosophically speaking, when you reviewed the studies that you used for this, the majority were in glioblastoma. But you said yourself you treat a lot of brain metastases, and this is a common question. Do you think that the utility there may even be, greater than in the GBM setting, where you get a better understanding of, is my patient really failing their treatment? Do I need to do an intervention for this, either radiation necrosis or advance my systemic treatment faster?
I do think, just numbers wise, there are more patients with brain metastases that we have this diagnostic dilemma of, after radiosurgery, things are growing and we don't know what it is. And we do scan after scan after scan and perfusion, and we have a whole program on chemical exchanged MRI, CEST MRI, and lots of people are trying, but no one's yet found the silver bullet in terms of what's like 99% accurate for determining or differentiating necrosis from tumor progression, and they can be managed very differently. And if we knew, we would jump in earlier with it. Necrosis, if it's symptomatic, you can use Avastin, or you could first use steroids, then you can use Avastin. You can use, you can use LIT now, right? There's all sorts of things. And if it's tumor, obviously, you're not going to use Avastin. You need to go back in. You need to operate or re-irradiate. And we're not doing our patients a good, we're doing them a disservice by just saying, well, we don't know, let's wait a little bit, because that's delaying everything else. And so you're right, there's a huge need for ideal imaging in the post radiosurgery setting.
Yeah, absolutely. That's kind of where my mind goes with this, without a doubt. We're approaching the end of the time. I really wanted to say thank you guys for coming along. I hope that this can get insurance authorization soon, so we can start ordering it and just see what we get. I think that's going to be the biggest hindrance, unfortunately. But when you guys are ready to do a multi-center study, hit us up too, because this is something we're very interested in. Again, congratulations, fantastic work, and thank you for choosing the JNO. And we'll see everyone else next week. We've got another one. We've got a nice string of webinars coming up. So thank you guys so much again.
Thank you.
Thank you.
Have a great day, everyone. Thanks.
Bye.
Thanks for joining, everyone.